Hi, my name is Dr. Dean, and I'm here with my friend Venzel Rucker. You want to introduce yourself?
Yes, my name is Venzel Rucker. I'm a strength and conditioning coach, and I'm also a physical therapy student as well. Thank you.
Yeah, that's awesome. I'm really excited about having you finally exit that program so that we can do more fun stuff, right? Okay, so Venzel and I decided today on this platform because honestly, like putting together a whole like video is a little complicated for us. And it is really just us and everything that we're capable of. So today we thought about, let's do sort of like, a podcast kind of setup.
Yeah.
And let's go ahead and pop the camera on it. And you can kind of, hang in there on the side and watch us if you want, or you can just listen. So today we're going to be talking about an article from, actually 3 articles from my blog series, and these are specific to the spinal stability. So we were kind of talking about spinal stability a little bit earlier, and I was like, hey, let's put something together specifically on spinal stability and try to relate it back to the physical therapy importance, and also, of course, core recruitment, core neutrality, all that. So basically, this is Article 13, 19, and 20 from my series, and then I also have specifically a podcast for 13, and 19 and 20 are recorded together. So this is Spinal Stability Part 1, and it's from my Pain is Not the Only Problem blog and podcast series. So let's talk about spinal stability. So when we just casually kind of think about, what does that mean, spinal stability? Like, what kind of keywords come up for you right away?
With spinal stability, keyword would be recruiting or recruitment.
Mm-hmm.
Would be a big one. Also,
you mean like motor recruitment?
Yes,
like
exactly.
active
right. Motor recruitment.
Your patient or your athlete's doing something.
Yeah.
Right. They're not sitting.
Yeah, exactly.
Right. And squeezing their right. Yeah, right.
Another one would be proprioception. That comes to mind.
Yeah, and just tell the folks what proprioception means.
So proprioception is spatial awareness. It's where you are in space and where things are around you in space, and being aware of their placement. That's what proprioception is.
And let's say your athlete, your patient, how do they understand? What part of is this from the brain? Is this like unconscious or conscious, or?
It's a bit of both.
So the brain is listening to the body.
Yes.
Yeah.
So it's getting stimuli, feedback, mechanically, and passing that information back retrograde from the muscle or the neurons wherever in the skeletal muscle
afferently.
System. Afferently, exactly. Yeah. And it's sending a signal to the brain, and then the brain goes through the process of understanding that, and then sends a signal back down for that muscle to do a certain
motor
action.
Response.
Exactly.
Yeah, so it's like a loop. It's very well understood, right? Yeah. So the reason why we wanted to talk about the spinal stability specifically is that there's an idea. We're kind of joking around a little bit, like arm day, leg day,
yeah.
Right? And then so the idea is that you can't really separate even like core day, like every day is core day, right? Because core neutrality is intimately connected with spinal stability, and we don't mean like spinal stuckness or stiffness, right? The spine is moving, right? But then there's this idea that, your shoulders, if you're doing something with your arms on arm day, are, connected to the spine. And so the whole, it's unavoidable. Core recruitment, spinal stability is unavoidable.
Exactly, because anything you do athletically or dynamically, it has to come from a stable core. Even if you go into core flexion, thoracic extension, you have to recruit the motor units first to be able to stabilize, then go into that action, that movement pattern. Yeah.
And so you could say like the core neutral follows you wherever you go.
Exactly.
Through those drills or cuts or swim or jump or whatever. Yeah. So I'm not going to read every single thing, but I'm going to be using prompts from my articles because it's just easier to remember. So we're just going to jump down and we're going to talk about, this is actually my definition in 2016. I started this research. So I'm just going to read all the way through. Spinal instability. This is a definition. Spinal instability is due to defects and deficits related to these 7 things. I'm just going to read all the way through. Related to the spinal motor experience with articulations in multiple planes of motion, of meaningful adaptive benefit, utilizing both aerobic and anaerobic energy systems and axial spinal loading while avoiding risk-promoting activities of position, duration, intensity, and monotony, and perpetuating certain biases and attitudes about spinal health. So I'm kind of giving myself credit for that. Okay, and so if you read the articles 13, 19, and 20, you'll see that there's a lot of, I don't want to say like debate about what is spinal neutral, what is spinal stability. So what we discover, and we'll cover this again when we read the other article, is that it's kind of a little bit of a joke. Spinal stability has unstable definitions, right?
Yeah.
So it kind of depends on who you're talking to. If you're talking to a radiograph expert, somebody who reads X-rays, or even advanced imaging, whatever. So they use certain very well-known angulations and relationships that are geometric, right? And measurements of millimeters, anterior or posterior, right? And a lot of those have names. We're not going to go through all those, but it's sort of this mathematical way of looking at spinal stability. So if you're a radiographic specialist, that's what you would do those markings, and that would be your interpretation. But if you talk to, let's say someone who's more, let's say like us, somebody who's more like about movement, sports oriented, they're going to talk about it more about the ability to resist displacement and sort of that elastic rebound. Like if the spine gets displaced, it quickly can find its
core neutral again, its center.
Right. Mm-hmm. Yeah. So we'll get to those. There's a couple of examples. So the point is that depending on who's defining spinal stability, you're going to get all kinds of different responses. Yeah. So, and we're not going to like pick a favorite because they all count one way or another. Okay. So let's break down this definition. Spinal instability is due to defects and deficits. So let's start there. So what would you say what's your difference? What's your definition difference between defects and deficits?
So the difference the difference between defects and deficits, one, you can change, the other you are born with. So defects, so if you were born, for instance, with a short torso, you can't change that. That's
right.
That's your genetics. A faulty movement pattern, though, that's a deficit. That's something we can address. So
right.
Yeah, that's my right. My interpretation of deficit and defect.
Yeah, and you can overlap that even to some people are more like type 1 muscle fiber, type 2.
Yeah.
They have a bias kind of right, and you can train all you want.
You're going to be super lean, or you're going to be a stocky guy like a sprinter, like a 100-meter runner versus a distance runner, 5K or a marathoner. Body types are different.
Right. Yeah.
They carry weight differently on their frame.
Okay. So so that's I agree. I totally agree. All right. So then, I need my glasses again. And just speak up louder.
Okay.
All right. So spinal instability is due to defects and deficits due to, and here's number 1, the spinal motor experience. So what does that mean to you, spinal motor experience?
Spinal motor experience to me, basically, I interpret that as being able to receive forces and being able to react to forces, like when I was talking about proprioception,
right?
being able to, know where you are in space and know where things are around you in space and be able to act.
Yeah.
So that's what that means to me.
Yeah, and so in the definition, that's kind of what I'm getting at in this smallest amount of words, is that the spine is part of the loop of afferent and efferent experience. It's not just a stick leaning up against the wall, right? It's having an experience. I like that a lot. Okay, and then the second one is articulations in multiple planes of motion. So that kind of goes along with that's sort of detailing the spine's experience, but we want to make sure we understand, like from another podcast and another article that I wrote, which is about sagittality, right? The idea that they're kind of stuck in that sagittal plane. The spine is only experiencing that sagittal plane, that walking plane of motion. Yeah. So the spine's getting 3 planes of motion at any time, and that they are of meaningful and adaptive benefit. So what does that mean to you about, in the definition of spinal stability, what does meaningful and adaptive benefit have to do with that, would you say?
Meaning and adaptive benefit. So I would quantify that as being able to be able to react to certain stimuli. So say, for instance, you were losing your balance, being able to catch your balance. So people who, have problems with their balance in the older population,
I agree.
That would be something that we would gear their training towards, is being able to be balanced, stay stable, which is core recruitment.
Right.
So once they have that principle down, then obviously we can take it on to being able to do things unilaterally. So we'll have them do more one leg balance work and other things of that nature. But that's what I'm talking about, progressively training that way. So
yeah, and I totally agree. So that's a great example. So meaningful and adaptive, we mean that the movements that the spine's doing in these planes of motion actually have benefit to the patient.
Yep.
Either to their ADLs or to their sport or to their occupation.
Yep.
So that there's some sort of restoration to purposefulness, right?
Exactly.
So we're not going to, I don't want to pick on physical therapy because, that's your world, but I know your plans are to, flip the PT world upside down, right? So the idea is that you're not doing exercises because they have a name. So you're not going to just do deadlifts for deadlift's sake, right? You're not going to squat for squat's sake, but that you're doing, the spine is experiencing these movement patterns and these shapes in relationship to the environment, like you said, like in balance or whatever, but that it has overlap and value to the specific patient, not to all patients, but specifically to your patient. Yeah, I like that. Okay, and then utilizing both aerobic and anaerobic energy systems. So why would we care about the spine doing aerobic or anaerobic, or why are we even thinking about that in a definition of spinal stability?
Because of the energy systems, the anaerobic and the aerobic energy systems, you have to deal with different muscle fiber types. So addressing that, what's around the spine, what's being recruited at certain levels of the spine, the prominent muscle type. So you have the fast twitch and the slow twitch, and then being able to train in both systems to build both systems up, as well as work on cardiovascular and respiratory health as well.
Right, and that just gets missed.
Yep, a lot.
Yeah. We talked about that in a other video, didn't we? That
about respiratory reserve.
TLJ.
Yeah.
Yeah, that C-pin thing, that was super great. So you just made a point about the tissue fiber types, like type 1, type 2, and having one is more about active movement that you could see, like that type 1, and type 2 that's more stable. Or is it the other way around?
It's the other way around. So type 2 is the quick twitch, and then type 1 is the slow twitch. That's more duration.
Postural.
Yeah, exactly.
Postural, right.
Yeah, exactly.
So then, someone might say, oh, spinal stability is all about creating stiffness or rigidity to protect the spine, when we're actually saying, oh, yeah, but we also need the spine to move around, right? So then we have to develop both systems. We can't just, again, have somebody do like dead bug and say we're creating spinal stability, when everything is, So I have a rescue dog, Brew, and he's in the studio with us, and he's having a little sort of a dream right now. And he's kind of singing, just really cute, isn't it? You probably can't hear it, but it is really charming. Anyway, just want to let you know we're not alone. So that's important. And then axial spinal loading. Yeah. So why bother with that in spinal stability or instability? What would the difference be of the spine, whether you're exercising it in upward fashion, or let's say like that dead bug, like laying on your back and doing a dead bug, even like on a BOSU or something that's super challenging. But if you're on the BOSU, what's the difference?
So specifically, the major point is how gravity is affecting the spine. That's a major thing that people don't take into account with their training. Most of the things that we do athletically or any ADL, we're in a vertical plane, so the weight is coming down through the spine, a compressive force. So being able to realize and with your training address that, that's key to basically understanding how our spine deals with certain loads, and gravity is a load.
Right.
Yeah. So
it is. Yeah. So that's right. And then I want to just add on to that by saying, and what's at the base of the spine?
At the base of the spine, you have the coccyx. So you have the you go into your pelvis, and those are fused bones. So obviously you're going into
that's the basement of the spine, right? So if the pelvis isn't underneath the spine, it's to the side or it's laying down. The base of the spine isn't that pelvic, sacral joints, SI joints, and all of that thoracolumbar fascia is turned off. I hate saying turned off. Pretend like I didn't say that, but that's really, it's important because that's sort of the home of the spine. Are those broad ilia, right? And we'll talk about that a little bit more. And then while avoiding risk promoting activities of position, duration, intensity, and monotony. And so my point here is that why bother to exercise and motivate the spine into stability if the exercises or the motions themselves are like super boring to the spine, right? So the intensity isn't high enough. There's kind of no limit to the intensity that this. I would almost say some people say, oh, I want to be careful with my spine. I don't want to overwork it. I want to protect it. And I'm going to say you do want to overwork your spine kind of as much as possible, almost too much, right? I mean, definitely with recovery, but, don't be careful. And we talked about this before. The difference between loading quickly and suddenly and creating that vibration, especially at that ground force reaction that's axially loaded, and then that slow loading like Pilates or yoga loading, right, doesn't create as much response to the spine because the load is too slow. Right. So what we're saying here is avoid risk promoting activities of position, duration, intensity, and monotony is make sure that the activities have benefit and value in 3 planes of motion, axially loaded, but at the same time, make sure you're not doing risk type activities. And I'm going to say one really risky activity for the spine is the elliptical. because there's that super short range. It's like a 16-inch stride length. I mean, that's and the feet are like 9 inches apart or something. I would call that risk.
Yeah, it's not natural because
right.
I have long limbs and my stride length is far beyond that.
Right.
So it messes with my turnover. It gets me going, but it feels really weird because now and then you're popping up on the machine. Now you're not in a proper. You don't have a proper stride length,
and you can't pop on an elliptical.
Yeah, because you go out to the ground.
Right.
If you pop off that elliptical.
And the common thing I hear about the elliptical is, it's like, yeah, my feet keep falling asleep. I'm like, then why are you doing it? Obviously, there's something wrong with the alignment of your nerves or your something, and it's like
sliding your feet. It's literally it's going in a cycle, but you're sliding your feet back and forth.
There's no heel strike. There's no toe off. Right. And then finally, perpetuating certain personal biases and attitudes about spinal health. And so I just want to make a point here that in much of my articulation, explanation, my messaging about kind of everything physical is that you can't ignore the psychological aspects. And even when an athlete has an injury, you don't just talk about the pain. You don't just talk about, how long is it going to be before I get back in action? What do I have to do? What's my treatment plan? There's always also this fear of like, oh my gosh, and when do I get to train again? Mm-hmm. Right? I'm going to be sitting on the bench while the rest of my team is playing, and like, what is that? Or being pressured by my teammates or my coach to play even though I'm injured. So there are all these psychological components that can't be ignored.
Yeah.
There's even diagnostically there's a diagnostic code for fear of not being diagnosed. Right? That's a real thing. So it's important to understand that whenever what we're talking about here is spinal instability, I wouldn't really call this an injury per se. It's more like a subthreshold microtrauma kind of situation. And that's a different conversation. If I could just look here quickly at the board, it's Article 17 is subthreshold microtrauma Part 1. And then Article 36 is subthreshold microtrauma Part 2. So you could look at that. Again, there's a podcast and there's also the article in the blog. Okay. While other processes are to be considered, of course, we talk about this too, inflammatory, degenerative, organic, and metabolic, the contribution of nutrition.
Yeah.
Right. Even to spinal stability. Why? Because if your discs are inflamed due to
have a high inflammatory diet, then obviously what that's going to lead to: more joint stiffness, and then probably some neurological pain because of that pressure building up and now sending signals through the neurons and the nerves through the spine because they're being compressed. Now you have those action potentials send off, and now you're perceiving that inflammation as pain. So,
right.
Yeah.
So let me ask you this about inflammation and diet. If the joint is inflamed, wouldn't that change proprioception?
Yeah. Yeah.
Who thinks of that?
Not many people.
Right?
Not many
so
people. Yeah.
Any clinician, basically, regardless of the injury, they could always start with a conversation about getting on an anti-inflammatory, lowering their inflammatory intake, right? Like, does anybody ask about alcohol intake? Do they talk about like the bad stuff, like smoking, vaping, drinking juice, bread, gluten, all those classic things.
Super high protein diets, because that's obviously going to trigger inflammation as well.
Exactly. Right. So we're just saying that, in large part, low back pain complaints are due to spinal stability defects, right? And there are other contributors other than the way the spine gets moved or used. Yeah. So another point here, spinal stability defects describe faulty patterns either learned or acquired. Defects can be learned from poor instruction, copycatting, you see that in gym all the time, and self-learning. And there's a lot of research about the delay in healing with self-learning, right? So that learning process should always be something that's part of a managed course of care. Like, you know what that means. Defects can be acquired due to poor observation or management, creep, that's that subthreshold microtrauma, misinformation, or personal bias. As we talk about personal bias, it could be like, hey, this is my sort of my go-to. I don't want to lose my job, and I sort mail, and I'm standing, and I'm on a fatigue mat, and I'm wearing, Hokas. Did I call them Hokas or Hoka? I can't remember. That's a whole nother conversation. But basically, it's like I can't change what I have to do at my job because, I have to have a paycheck. So that becomes a personal bias. I don't want to change my job, right? And so at one point, I had really horrible carpal tunnel, years ago. And I had a landscape contract design build business. And it got to the point where I had to bring a bucket of ice every day to the job and plunge my hands every 20 minutes into a bucket of ice. And then eventually I was like, I just can't do it anymore. So I had to make the decision to change my job in order to, not go further because I didn't want surgery.
Yeah.
So that's important to also to recognize that there, in addition to the mechanics, which we're really good at, there's also this component of emotionality, and there's also this personal bias, and that can't be overlooked. And any clinician can ask that. Yeah. Right? So like even right now, I'm dealing with a sort of a weird leg kind of neurology kind of situation. And, my doctor's like, he's a super great guy and he's trying really hard, but he's an MD and his wheelhouse is very limited, as they all are. In cases like mine, he's kind of threw up his hands. But, he easily could have jumped into the anti-inflammatory or checking out my diet. Yeah. He could have easily gone into my personal biases or my, right now the issue is my fear of not being able to teach yoga or not to continue to teach tennis, right? Because of this problem. So that could be addressed without medication and surgery with anyone, right? So I'm bringing that up in spinal stability as I do with every topic because it just can't be overlooked.
You were talking about earlier about the monotony of, the medical field, and training in general. You have a certain cookie cutter way of doing things. You're going to do what you're comfortable with versus looking at the problem in a holistic approach.
Right, and things that anybody could do or refer to anyone. Yeah. Spinal stability requires that the spine have ongoing workloads in a variety of positions and patterns each day. These workloads must be meaningful and not destructive. These workloads should support a desire to improve spinal stability as a priority. The spine must be primarily loaded vertically, we talked about that, oriented with gravity with episodes of rotation, lateral flexion, and extension, and elevation, like standing from a squat. So we talk about all the time those 3 planes of motion, but when you're at the bottom of a squat and you thrust up, right? Or even if you go to to post or to drive your leg down, there's acceleration. Acceleration creates gapping in the joint, and I think that gapping or even the compression can't be overlooked as a plane of motion. Because it's, wouldn't you say compression has a proprioceptive pathway?
Yeah, it does.
I would you say, like, I've done this to like distract your leg, right? Do this leg distraction thing in my office, and you can just see the patient's eyes roll back in their head because it's just the gap. And even with arthritis, if I would say gapping of the fingers, like aided, like, going to the chiropractor or physio or PT or whatever, and gapping the fingers is the gold standard care for arthritis. Because when you gap the fingers, it gives the bone alignment a chance to come back together in a slightly new plane of motion, maybe more functional. So we can't overlook compression and distraction as a real plane of motion. The workload should occasionally represent aerobic work, such as vigorous long stride walking, or seated or standing rowing, which I prefer standing rowing, and it's even better with rotation. Standing vinyasa yoga, things like that. Aerobic workload should cause breath-seeking, deeper ventilation. So you made a connection like to the ventilatory or the breath demand component to, I want to say, like waking up your spine, right? So the breathing diaphragm is attached to the vertebrae. Yeah, and the ribs are attached to the vertebrae. I mean, it's all together, right? So you could almost say like a spinal stability drill almost has to incorporate those breath rhythms, and those breath rhythms also contribute to core neutrality. Yeah,
and even when we're talking about the posting, our hip flexors are psoas major. So with the inspiring breath and the depression, the respiratory diaphragm, you get stability in a post.
Right.
So it matters a lot. Your inspiring and expiring breath.
So to get away kind of like from the classical PT model, we could say something that's a little more accessible, or things people can do at home that they kind of know or could be supported. Workloads should occasionally represent aerobic. We talked about such as strength training, burst activities like ladder drills. Anybody could do a ladder drill, Correct system. Basic drill sets, 100-meter sprints, wouldn't you say?
Yeah.
Right? Is there anybody who can't do a 100-meter sprint to the best of their ability? Take a rest. You might
be out of shape, but you could do it.
But anybody could do 50 meters.
Yeah.
Right? Tennis stroke drills, baseball pitching, for example. So what I'm trying to get at here is you don't need a gym. You don't necessarily need specific instruction. But we have a ton of stuff already on YouTube, but there's plenty of stuff on YouTube, right? You don't need specifically to have to go to the gym. So we just made that. Diversity and meaningfulness in work should be explored, and monotony should be avoided, such as walking every day on a motorized treadmill or on an elliptical or stationary cycling, which is also as tragic as elliptical machine. But I do like stationary cycling, right? As an interval or, kind of working it into your workout, but to have it be like your thing, and that's what you do 3 to 5 times a day and you don't do anything else, it's contributing to spinal instability, right? Because there's no ground force reaction. The spine's not really axially loaded, and the pelvis is basically not absorbing anything.
Exactly. And especially with my clients specifically, I make sure they do not rest when their hands on the bike,
on the bars,
the bike bar. I have them sitting straight up, and then I have them also using their arms.
Right.
So with a nice little
I love
arm
that.
swing.
Yeah, I love that.
Because I want engagement of your shoulder girdle,
yeah,
and then making sure you get core recruitment.
Right.
So I'm very big into making sure it's a whole body experience when you're on the bike, especially for the warm up and cool down.
Yeah, I totally agree. I mean, I love the stationary bike. Especially a really good quality one. Get clip-ins, get some really great music going. It's super, super motivational. And then finally, spinal stability workload should avoid personal biases such as avoidance due to fear of pain or flare-up, or avoidance due to disinterest or claiming that you're too busy. The classic example we already brought up is not working the spine in order to protect it. Yeah, so that's in our world, that's not an argument. So we're going to move on to the next one, Article 19. Same thing. Pain is not the only problem. Spinal stability, part 2. So part 2 is basically some contributions by different authors, so that you can understand that spinal stability isn't just something I define. The problem is that we don't agree on the definition of spinal stability, and because all the disciplines don't agree, then what becomes the course of care?
Yeah. Right.
So we need to understand what the outcome parameters are. So if I say I'm going to use, Harrison lines or Reiser-Ferguson lines or measurements, that's all good and dandy. But what's your treatment plan after you get those angles measured, right? So the idea is that you're going to improve those angles, but I'm just going to say don't diagnose something unless your discipline has a solution.
Yeah.
Right? Don't just draw a bunch of, and I don't mean it, I'm going to look out there. I don't mean any disrespect to the discipline, but don't draw a bunch of lines on radiographs and then say, yeah, here's the problem, if your discipline also is not offering the solution. So what we're saying is in our world, we're going to understand subthreshold microtraumas. We're going to talk about faulty movement patterns as a diagnostic benchmark, but then we're going to create a course of care within our discipline to solve the problem as well.
Yeah.
Right? So classically, I don't remember which article or which podcast I talk about this, but don't ever diagnose something you don't have a treatment plan for, because you're just going to scare the patient.
Mm-hmm.
Right? So unless you're willing to do both, don't do either. Don't create like you have somatic and segmental dysfunction of the neck, right? M99.01 or whatever, right? Unless you have a treatment plan. And I don't mean 1,000 chiropractic visits, right? Prepaid on a Visa card, $50,000 or whatever it is. Whoever's doing that, please stop doing that. But what I'm saying is that the treatment plan is at two things. It's at low cost, right? And it's the smallest amount of time.
Exactly. That's all
Get your patient back in action and impress them with your clinical skills, right, as quickly as possible. So I'm not going to read all these because most of them aren't that interesting. So we're just going to talk about, let's talk about the motor activation around the spinal trunk, because we both are pretty passionate about that. Mm-hmm. Foremost, spinal stability requires motor activation around the spinal column, the trunk, while the spine is aligned axially with natural gravity and must be synchronized with the adjacent motor group. So you talked about psoas, right? Stabilize the pelvis, knees, and ankles, even with overhead activities. These motor activations must be synchronized with core recruitment. We talked about that, and horizon line gazing. Now, I keep bringing up horizon line gazing, and I talk about this with other clinicians or other coaches. They're like, what is that? Like, who cares?
That's everything, because you have that ties in with the proprioception and spatial awareness. You have to see where you're going. You have to see what's around you. If you don't see where you're going and know where you're going, then when you look up, now you have to make a sudden change versus you already saw it. You already made that correction where it doesn't have to be so drastic. Like, for instance, if I was going over a hurdle, I'm already looking at the next hurdle before I went over that one, because I have to know when I need to make a slight adjustment. Because if it's too close, when I make that adjustment, I'm going to be in the air longer versus touching down as quick as possible.
Right.
So that ties into spatial awareness, knowing where I am between the hurdles and knowing where that hurdle is and how I need to correct for it.
Yeah, we talked about that before, that readiness and awareness, and exactly. Awareness being, anything around you that can help you with your activity, right? Yeah. And so, hurdles are level. They become little mini horizon lines,
Yep.
right? And even if you're pole vaulting or jumping, there's that horizon line. Horizon line becomes your gauge or your measurement, right?
Yep.
So, that's important for the spinal stability, is having somewhere a horizon line. So and I've even seen this like in a client who's like 92. She was in like a really nice retirement home on Wilshire Boulevard, and she was losing her stability. She walking, so she ended up with one of those horrible walkers, which eliminates that the shoulder complex counter articulation to the pelvis, right? This that, right? So the arms become fixed, and so that those slings die, right? So she's on one of those horrible things, and I hope someday I can reinvent that thing so that at least, anyway. And those tennis balls, what is that? tennis balls?
I guess it helps it slide. A nice little slide.
Well, then why don't they just come with tennis balls, right? So, her problem wasn't so much that she lost her balance; it's that there are no horizon lines. So I did a little experiment. I put her at the end of a really long hallway. It's probably 100 feet, maybe 120 feet. Okay. And I took a blue tape and I marked the wall with a piece of, like 4-foot piece of blue tape about at the height of her eyes. Took her to the end of the hallway, took away her walker, and you know what? She made it all the way down without falling. I said, I just want you to look at the blue tape, because the blue tape became her ability to understand where level is, right? So instead of looking down, she's looking up, which is, right, aligning the inner ear with, that's related to horizon line gazing, right?
Yep.
She made it all the way down the end of the hall. So my argument is, why don't all these senior homes have their hallways, at the end of the hallway, there should be a marked line. Don't put a picture of trees and leaves and butterflies, right? Put a horizon line. I mean, the horizon line can be made out of butterflies and leaves, right? But what I'm saying is that that's a really simple thing to solve, and it definitely is involved in spinal stability, right? The ability to create that axial position, not to be overlooked. And then we talked about, and there's a little notation on here on that the fact that core neutral follows you wherever you go.
Yeah.
So there are many neutrals. There's just one core neutral, right? That's that stuck kind of sports ready position.
Yeah.
Right. I mean, we could be in a version of a neutral right here. And then there's one here by Reeves et al. 2017 that I really like. The spine is either stable or it's not. There is no index. It's either stable or it's not. So let's create the definition, because there's no, it's 20% stable. What is that? It's 3/4 stable, right? It's grade 1 stable, grade 2 stable, right? It's either stable or it's not.
Yeah.
Yeah, and then I like this. The pelvis is the foundation of the spine because it provides with the locking mechanism. The sacrum is essentially encased between the broad ilia. However, the pelvis, you'll love this. The pelvis itself does not have a home position. It is essentially floating. We've talked about that before. So check this out. There are 16 muscles attached between the spine and the pelvis.
Wow.
Okay, and there are 48 muscles attached between the legs and the pelvis. Therefore, 3 times more work is being done to stabilize the pelvis than to stabilize the spine. The pelvis, 48 muscles between the legs and the pelvis. Now remember, we're talking about from ground force reaction, we're talking about accountability from the basement up, not from the roof down, right? So if there are 48 muscles attached to the legs, attached to the pelvis, but only 16 from the pelvis to the spine, I'm going to say that anatomically, the design of the body is primarily to stabilize the pelvis, and that the spine is attached on a stabilized pelvis, not the other way around, which means ground force reaction, right, from the ground is required to activate those 48 muscles. So if you take this patient and you lay them down and you have them do, I mean, I'm not going to pick on the dead bug forever, but it's a good one, right? But if you're laying down, now those 48 muscles that stabilize the spine aren't part of the drill anymore, and there's no ground force reaction, and there's no axial loading. So, right? So I want to be careful when we're talking about spinal stability that we don't miss the cues that cause proprioceptive engagement, like you said.
Yeah, and that's a big thing too, because dealing with the dead bug, people usually they start to form an arch in their back, and then they're like, as soon as they extend one leg, then they complain of back pain. And one of the reasons why is what you just said: those muscles are not cued, they're not turned on. So now that you have to autocorrect for that by telling them in the posterior pelvic tilt, keep the back flat, versus if you had them standing, they would already be engaged.
And we were talking about this a little bit before, because I was impressing Venzel with my 350-pound single arm fly machine set of 30 repetitions, which equates to 4.5 tons of work done with my skinny little pec muscles on one side for one set of 30, right? So the idea is you can take a totally dysfunctional, to me, exercise like a bench press. You can reimagine it into something that is, and just picture in your head that video of me in that sort of lunge position. I was in the classic core neutral position, right?
And
not
drop step. That's what you were.
It was. Yeah, it really was. And I wasn't sitting on the bench, and I wasn't using the backboard. I was floating in midair, with loaded 350 pounds on one arm, although it was my right arm. But I do both. I do 3 sets, right? So the idea is you can take that dead bug and do it standing, right? So get in the same like 90-90 position, and this time put a Swiss ball on your legs, on your thighs or on the knee, and then put your elbows on top of that Swiss ball, right? Standing like in core neutral. Now get pelvic neutrality and have them drive their elbows down into that Swiss ball, right? Into the knees, and have the pelvis thrusting up while the elbows and the lats engage down. Standing dead bug. All day long, completely functional. Now take that and have them go for a walk. Walking dead bug with that Swiss ball. Right? Now take that same dead bug, standing dead bug, and eliminate one knee and the contralateral elbow. So now you're getting an angled drive across the body into the contralateral knee, and step it back sequentially in repetitions into a posterior lunge.
Wow.
From the dead bug.
Ooh, that's going to be a lot of core.
Right?
Core recruitment.
Now, instead of stepping back into the lunge and the dead bug, reach the leg back without touching it to the floor and snap it back into quick hip flexion. Okay? So I do that drill, right? That's my version of a super functional, super challenging, super core engaging spinal stability drill.
Yeah. That is
so. When we're done, let's go do it, because it's it's very challenging. I was going to say it's mental, but it's very challenging. So it's we're going to try to wrap this up pretty quick here. So this is Article 20, and this is part 3 of Spinal Stability. And now we can't talk about any kind of therapy without addressing nutrition or the emotional or psychological components. But we can't, I'm actually going to look at the camera. You also can't ever diagnose and treat or create a course of care ever without appraising quality of life. Okay, now who cares how great you are? I don't care if you're the greatest clinician ever, right? If you're not improving the patient's quality of life and they can prove to you that their quality of life is improved, you're not doing your job. You're not doing your job. Okay? So let's talk about that related to spinal stability. Appraising quality of life should be evaluated then when case managing the low back pain patient. Oral and injectable medications are commonly prescribed by the medical doctor for pain, inflammation, and spasm. When medications become the first line or gold standard in low back pain case management, contributors such as lifestyle, work, and recreational activities, patient expectations, and underlying faulty movement patterns are never evaluated and considered. Right?
Yeah.
So if you're just going to do drugs, what happens to the poor faulty motor pattern? Okay, so medications have side effects, including addiction. Medication does not involve patient education regarding the underlying problem. Only addresses symptoms. Are you ready? Medications can't correct spinal stability. Done.
It's simple.
Okay, we're all done with medication. All done. Never ever.
Yeah.
Okay.
You can't treat the issue.
Wrong doctor, wrong treatment. Okay. So now we're gonna talk about surgery. Okay. Now this isn't a pick on podcast. I'm just saying things that are true, right?
Yeah, and it's we want the best for those physicians' clients, as well as our own, because and at the end we're here to perform a service for people to feel better, like Dr. Dean said, the quality of life. We're here to improve that for our clients. That's what we're here for. So remove ego from the situation, apply what you have learned, and continue to grow. That's what this is all about.
Yeah. And that's what we're about is growth. Yeah. Okay, so I'm just gonna make this other point here. Surgical consulting is a first line of low back pain case management. And of course, we're still talking about spinal stability. Attempts to correct a picture of a spine and not the function of the spine. Protecting the patient's quality of life standards should insist on employing a rigorous conservative care approach, specifically to establish spinal stability. Surgery causes permanent reconfiguration. Surgery causes permanent reconfiguration of tissues into scar that causes further complications, since scar can't contribute to the physio-chemo sense signaling or proprioception required to activate spinal stability. And then physical therapy is the third part of this part 3. So the point is that scar can't produce a sense signal, or it's not proprioceptively active.
Yeah, and that scar tissue becomes a part of the dysfunction.
Right.
So. And
that can't change.
Yeah.
Yeah. And it also doesn't have there's some debate, but it doesn't have a nerve supply. Physical therapies are prescribed by medical doctors in an attempt to provide palliative and conservative care. PTs use massage, temperature, what I call plug-in modalities, infrared, ultrasound, interferential, etc., and pre-formatted exercise from charts and handouts. While temporary quality of life may be addressed with palliative care by the PT, the therapy can be inconsistent, nonspecific, ineffective, inaccessible, and in large part passive. And so what I mean is, we don't want to just deal with symptoms. So if I come to the PT office, I don't want just an ice pack.
Yeah.
An ice pack isn't going to create spinal stability, right? Because we agreed that's learned. Oh yeah, and then we kind of talk about the dead bug. Okay, and then the fourth part here is about chiropractic manipulative therapy. We talked about this a little bit already. Involves manipulations of the spine at a segment or joint that is identified as subluxed. This is the classic bone out of place chiropractic reductionist theory explaining low back pain. So it's not. So there's a statement here from Globe et al. 2015 that I like. It is rare that a patient would require 4 visits per month to manage advanced or complicated low back pain. It is not in the patient's best interest for the chiropractor to use the least evidence informed chiropractic techniques as their first line of approach. So I'm not picking on chiropractors because I'm a chiropractor, but I'm just saying, don't just do, the crack thing.
Yeah.
When there's no science behind it. When we're talking about, Venzel and I are presenting these very high level, very well thought through cognitive courses of care that respect things like quality of life and patient emotionality and palliative care and actually knowing what's better for them. So to kind of sum it up, I'm going to present this as the gold standard for case managing the patient would be employing the whole patient approach, which I kind of coined that some time ago, since it addresses the underlying mechanisms and contributors of spinal stability, patient values, and expectations. The whole patient approach does not fit into a box of medical practices or beliefs, so nobody owns that, right? So the benefit is that anybody can use it. So any MD, orthopod, anybody in conservative care, oriental medicine, chiropractors, physical therapists, anybody, even a coach, right?
Yep.
A strength and conditioning coach or specialist, they can use the whole patient approach. Nobody owns that. So that means it's completely accessible, and it doesn't have to be learned. It just has to be respected. The whole patient approach combines science with an equitable perspective that reimagines better patient outcomes. The whole patient approach involves a brief consultation with the patient to explain the value of movement and spinal stability in their course of care that can begin on the same day.
Yeah.
So whole patient approach concept you could start that immediately, right? By just, all you have to do is tell the patient, I'm going to be using the whole patient approach. We're, there's nothing missing. We're going to take care of the whole deal.
And that changes a client's outlook too, because if you can have them do something as soon as they see you and they see a result, now that deals with the psychology like we talked about before. So you want the patient to adhere to what you're giving them. So you have to show them what you have them doing works. So
right.
Once they see that it works and it's immediate or in a shorter amount of time, they're like, okay, I can deal with this approach. I like this approach. And 2, obviously, following up with your clients or your patient is going to be a big thing. But this is the framework we want to work in, making sure that the patient's psyche is taken care as well as their body. So.
And their values, their expectations, right? That's all kind of built in together. And highly overlooked. I think a lot of classical MD type care kind of begins with trying to define the problem and then looking at the problem as like a knee problem, but they forget that the knee is attached to a person, and those person has quality of life goals. One which is maybe getting back on the tennis court as quickly as possible. Yeah. So like, when can that happen? And, and then getting some sort of positive feedback from your care provider. Oh yeah, you know what? I can take great care of that. I'm going to find you a really amazing tennis specific PT or a chiropractic physio, like somebody like myself, somebody like you. And I'm not going to pretend like I can help you with that. I'm not even going to pretend that classical physical therapy can help you. That's, I want you to feel like a somebody who's already on your team, like a tennis therapist who gets how important it is that you get playing right away, and whatever that
Exactly.
fix those faulty motor patterns or whatever it is that has to happen, and that patient is just going to exhale.
Yeah, it's all about RTP, especially when you're dealing with athletics. Return to play. They want to get out there. Athletes don't want to sit on the sideline. Like it can become you can deal with things like depression. So from just not being able to perform something that you committed your life to, you put so much time into it. You want to be able to get back on that field or that court and be able to be right on it again.
Right.
So you have to be able to implement proper strategies so you won't end up out for even longer. So
and there's also this possibility that the care that you get, this clinical care, could possibly put you back into your sport even in a better place.
Exactly.
Not just
not where you were before, but even better.
Just dealing with the injury itself, but dealing with the mechanics and that are behind all of that. So as usual, we love to kind of break it down. I hope you really enjoyed this talk about spinal stability. You can see the whole series. There are 43 articles and podcasts that go with the series. And it's designed specifically for low back pain. But I think the theory is good. I could kind of apply it to anything. So let's just get out of here. Thanks for joining us. My name is Dr. Dean.
And I'm Venzel.
Thanks so much. And please email us and comments, whatever it is you need to do to get our attention. We're happy to help.
You guys have a good one.
Thanks.